Our event recording is in progress. It is 11:03. We're up to 183 participants, and I'm going to wait one more minute before I begin our web event. It is 11:04. We are going to begin our event. We currently have 190 participants in the call. So welcome. Good morning. Today is May 6th, 2020, and this is our seventh in a series of weekly calls for Medicaid behavioral health providers. We are seeking to provide verbal updates on our response to the COVID-19 state of emergency and associated guidance and provider flexibilities. My name is Dr. Alyssa Ward. I am the Behavioral Health Clinical Director at the Virginia Department of Medical Assistance Services. We appreciate you being here with us today on this WebEx event, and due to the large number of participants, everyone will be muted today except for our panelists. If you've been on the past calls, you have seen that we have been answering your questions live in the Q&A function of WebEx. This is Mental Health Awareness Week, and in the interest of our own mental health and the preservation of our resiliency, we are going to be very present on our call today. That means we are not going to answer those questions live, as it does put quite a demand on us to be multitasking throughout the course of the call. So we do encourage you to continue to ask those questions, and we will be as responsive as we have shown to be ourselves to be during the state of emergency. We would just prefer that you submit those questions to the enhanced BH and SUD mailboxes at dmas.virginia.gov. If you look in the chat function, Laura has provided those in written form there. We also have those on our first slide. So your questions, again, welcomed as always. We just would prefer that method today. Please reserve the chat function for if you have any type of technological issues or you need to let us know about sound or video issues or logistical questions today. It is, as always, possible to listen to this event via phone, and we're mindful that many or some or many of you could be calling in via phone, so we will be detailed in our reporting of what is shown on the slides, but do encourage participation on your computer as we do have slide content. Thank you again to every single one of you for everything that you are doing to serve Medicaid members during this state of emergency. Your collaboration and feedback has been truly unprecedented, and 7.5 weeks into this experience, we still continue to receive a very high volume of emails and calls and reach outs from you all in regards to clarification, and also at this point a bit of a shift in terms of wonderment that we are in with all of you about what direction this will take. We know that many people are wondering about what flexibilities may change in the face of Governor Northam's phase 1 implementation that he announced just recently. And we don't have any specific information for you today in that regard, though we are staying, of course, very apprised to movements toward changes in the way that we're functioning in terms of social distance and the Virginia Department of Health's guidance and the testing and COVID positive numbers, and making our best scientific guidance available in terms of how we move forward and how that impacts our service flexibilities. So the nature of some of the questions that we are getting is evolving as the state of emergency and the COVID-19 situation evolves. And we, again, are committed to being in as transparent of communication as we can with you, and that's why we are continuing to do these calls. We'd also like to reference the two memos that have been formally released by DMAS providing guidance on provider flexibilities that have included behavioral health content. Those are published on the DMAS website and portal, as well as the memo that was released yesterday on flexibilities for the DD and CCC Plus waiver providers. Our frequently asked questions for behavioral health services have been posted on the DMAS website, and we have that up on the screen right now where you can see where that frequently asked questions document, as well as the recordings of some of our past WebEx events are located. We will continue to update that document and to review frequently asked questions on these calls. We are, for the time being, going to stay with this biweekly cadence. I'm joined again today by Dr. Cleopatra Booker, our Senior Program Advisor in Behavioral Health, also by Laura Reed, our Behavioral Health Services Manager, who is over both mental health and substance use disorder services, and Anna Shally, our Support Akron Manager. So on today's call, we're going to go over some of those frequently asked questions that are in relation to our second guidance document, the second memo called Behavioral Health and Arts Provider Flexibilities Related to COVID-19 that was released on March 27th. We also have some new information to provide today, and we want to just have this opportunity to clarify some of the things that we see most commonly in our mailboxes. As always, I'm going to start with just a few global statements for those of you who may be new to the call. 2 weeks ago, we moved to bi-weekly provider calls, and as I just mentioned, and if the state of emergency or policy responses evolve in such a way that weekly calls are necessary, we will absolutely move back to that. But for now, we will remain on this bi-weekly cadence, and we want to take a breather and protect our resiliency for the long haul. We know you're trying to do the same. As noted on that last call, we're pleased to share that we have been able to upload the documents that you see on your screen, which is a good resource for everyone. On this COVID-specific section of the website, we have one-pagers, documents that we hope will be helpful to members and providers, including a telehealth guidance document that was adapted from our colleagues in Hawaii. Do want to confirm today that our 1135 waiver was indeed submitted, and we are still awaiting approvals from CMS. That is a whole process. And we are in conversation with CMS around that application. The Appendix K was approved. And again, we just want to assure you that we are working both in partnership with our sister agencies, and Dr. Booker is going to speak a bit to some congregate care guidance that we worked on through those partnerships today. And we are also working closely with our other DMAS divisions to assure that Magellan BHSA and our MCO contractors are following through with the guidance and that we're answering any questions that they have about the implementation of those flexibilities on their side. And again, we appreciate any feedback about any trouble spots that you're seeing in that process. So at this point, I'm going to turn this over to our next panelists who are going to speak to some additional resources and some frequently asked questions regarding provider flexibilities. So thanks so much, and I'll be rounding us off at the end today.
Hello, everyone. This is Cleo Booker, the Senior Behavioral Health Program Advisor at DMAS. Can you all hear me okay? Dr. Ward, can you hear me?
I can.
Okay, great. At this time, we're going to move on to specific behavioral health updates, and one of them has to do with what Dr. Ward was just referring to. There has been a multi-agency initiative to put out directives for children's residential services and for congregate care settings. This directive was sent out to providers and posted on websites on April 24th of 2020. And within this presentation here is the link to how you can get to the memo or the directives that are posted on the DMAS website, as well as, I believe, DBHDS, Department of Behavioral Health Developmental Services, as well as DSS, Department of Social Services, also has the directives posted on their website. The next slide, we're going to talk about a few kind of key points within that memo, just some sort of, reminders that I just kind of wanted people to pay attention to. Directives highlights. Residential and group care programs should continue to support service recipients currently in the services and those that require admission to residential settings during COVID-19 state of emergency. For behavioral health, treatment teams should consider the frequency of face-to-face engagement with other residents and staff, and use of alternative means for delivery of services. Although face-to-face contacts may be limited, the facility should continue to maintain a person-centered care as well as trauma-informed approach for individuals, especially those that are children, still continue to need that interaction to grow and develop appropriately. To prevent the spread of COVID-19, providers should consider restricting visitors, ensuring that group activities and dining are done in groups of less than 10 people, and adhering to social distancing protocols as much as possible. It is important to note that also VDH released that one of the populations that are considered a public health priority are those that are persons with COVID-19 symptoms and they reside or work in a congregate care setting, such as a group home. And congregate care settings are inclusive of group homes and psychiatric residential treatment facilities. Residential and group home providers can continue to admit individuals that they normally would admit to their facilities, meaning that there is no need for facilities to shut down their admissions at this time, especially if you do not have any positive COVID-19 individuals or anyone that is showing any symptoms. You can also admit individuals who may have been in a hospital where they may be a COVID-19 case. But we want to encourage the congregate care providers that they should adhere to infection prevention and control practices that are being recommended by CDC. Also wanted to point out here that DBHDS has given directives for how providers can request temporary service locations or temporary increase in bed capacity. Please follow the DBHDS guidance, and that information is on their website in regards to how they should be notifying and getting approval from the Office of Licensing to be able to do this. Also, for DBHDS licensed providers, there is additional information that you can report when you have a confirmed COVID-19 case. Please report that into the CRIS reporting system. This initiative started in March. And so if you have any COVID-19 cases, it's very important that you report that into the CRIS reporting system so that the state can start capturing that data. DMAS specifically is allowing for medical necessity for continuation of care to be waived if the individual is unable to transition to lower levels of care due to COVID and quarantine scenarios. In these situations, the provider shall coordinate with the members' managed care organizations or Magellan of Virginia, the BHSA, and submit the following information. Please make sure that you note that there are barriers to discharge related to COVID-19 and what those are, describing attempts to overcome these barriers, restrictions, and or limitations for step down that has been identified, evaluation of aftercare services available in the community, agencies the individual has been referred to, and how the treatment plan and goals will be adjusted to sustain current progress and prevent regression. Please note that the MCO or BHSA, DMAS, has the authority to deny the continuation request. So although this is being allowed, it is not necessarily a mandate that anyone has to approve. If no one is meeting medical necessity for continuation of care, it is not an automatic approval. So it can be denied. or the MCO could decide to negotiate a single case agreement, meaning there may be a potential difference in rate because the individual is no longer meeting medical necessity criteria, or the request may just be approved. So please note there are nuances with this ability to be able to continue providing congregate care, group home setting, and patient care settings to individuals that are no longer meeting medical necessity criteria. I also wanted to point out that for Medicare specifically, I don't know if any of you were aware that, or some of you, I know that some of you that do Medicare and Medicaid services were aware that for Virginia and Medicaid, we were allowing telephone only billing to occur for behavioral services, including traditional and the CMHRS services. However, Medicare was not allowing that until last week. So now CMS is also, Medicare is also allowing behavioral health services to be delivered via telephone only, audio only communications. And the full list of telehealth services that are eligible to be reimbursed by Medicare, including audio only, can be accessed via this link, the CMS website. If you have a client that has Medicare and Medicaid, please remember that Medicare shall be billed first for the services that are covered by Medicare. And then after that, you can bill Medicaid. Another very important reminder, please remember to obtain an authorization from the MCO or the BHSA first for services that require an authorization prior to submitting the claim. The 14-day allowance to start the service prior to obtaining an authorization does not eliminate the requirement for providers to obtain the auth prior to billing. The 14-day allowance also does not guarantee any authorizations or payments. Medical necessity will continue to be applied for service authorization requests. So please, please, please remember, you must get the authorization first and then submit the claim. If you do not, the claim will deny. And at this time, I'm going to turn it over to Anna for ART updates.
Actually, you're turning it over to Laura Reed for ART updates. Good morning. Hi. So we wanted to provide one very important update this morning, an important flexibility that was approved just this week. So DMAS is allowing flexibility of the rule, which limits the reimbursement of medication administration encounters within OTPs to only those encounters when the member is presenting in person daily to get their medication dose. The OTPs have received approval from the State Opioid Response Authority to administer medication as take-home dosages up to a 28-day supply to minimize exposure of COVID-19 to staff and patients. As a result, DMAS is allowing for the reimbursement of the medication encounter for the total number of days supplied of the take-home medication. Again, this flexibility is very crucial to our OTPs to minimize face-to-face contact during the emergency. This information will also be added to our next COVID-19 guidance memo, which we are currently developing. So this is a really important flexibility for our OTPs, and we're really excited that they're going to be allowed to do this for our members and our community. So now I am going to hand it over to Anna Shalley, our Support Akron manager, to review some important resources.
Great, thank you so much, Laura. My name is Anna Shalley, and I'm the Support Act Grant Manager. The purpose of the Support Act grant is to increase the treatment capacity of providers participating under the state Medicaid program. The grant team recognizes new barriers substance use treatment providers are experiencing during the COVID-19 state of emergency, and we are offering technical assistance and training webinars focused on substance use disorder-related topics and treatment practices. These technical assistance and training webinars are designed to increase substance use disorder knowledge and to provide support to anyone who serves Medicaid members with substance use disorder. The overall goal of the webinars, as well as other grant activities, is to increase addiction and recovery workforce capacity while also creating a culture of understanding, empathy, and support for individuals with substance use disorder in various workforce settings. Here is our schedule of upcoming technical assistance webinars. These webinars are provided by our behavioral health addiction specialist, Paul Brassler, and our addiction medicine specialist, Dr. Mishka Turplin. We have several topics offered throughout the week, and then a weekly question and answer session on Fridays with both Paul Brassler and Dr. Turplin, when we invite you to bring any questions you may have about clinical practice for our experts. These Friday sessions have included, for example, questions about stimulant use, withdrawal management via telehealth, managing groups via telehealth, and how to engage with clients resistant to using telehealth services. We greatly appreciate providers' participation, conversation, and willingness to share their challenges and successes during these sessions. Each webinar is provided via WebEx and can be accessed through these links. Advanced registration is not necessary. Next slide, please. You may also go to the DMAS website shown here and navigate to the Arts page by clicking Arts under Programs and Services on the left, and then scroll down to the Support Act Grant section, where we have a link to a PDF of our schedule of trainings and webinars. Next slide, please. Our webinars have been reviewed across the Commonwealth. This map shows the viewership of just one of our webinars. We're really excited to have so many providers tuning in, and we hope this list and reach will only grow in the coming weeks. Next slide, please. We also want to provide some resources for accessing naloxone, the opioid overdose reversal medication, also known as Narcan. DMAS, as per the March 27th memo, advises the prescription of naloxone to all individuals who use substances, especially as community-based distribution may be interrupted due to COVID-19. Medicaid will reimburse for naloxone/Narcan. There's also currently a standing order in Virginia which allows Virginians to go into a pharmacy and request naloxone without a prescription. There are several online opportunities to be trained in the administration of naloxone that we'd like to highlight, including the DBHDS Revive program, as well as from the website getnaloxonenow.org. We also would like to inform you of a program by the Virginia-based nonprofit, the Chris Atwood Foundation, which is providing free naloxone to any Virginian, regardless of insurance, via U.S. mail upon completion of this online form. Now I will turn this back to Laura Reed. Thanks, Laura.
Thanks, Anna. So I have a couple more resources that I wanted to provide to you all this morning. So the first resource is the EMED Atlantic Telehealth Resource Center. And I know Dr. Ward has attended one of their trainings and thought it was really great. And they have a great website specifically for COVID-19 and telehealth resources. You can see they have different resource guides and different videos about getting started with telehealth, and even some specific information about telehealth for behavioral health services. They also have a section on their homepage about funding opportunities. I believe these are grant opportunities potentially for telehealth resources, so I encourage you guys to check those out. The next resource is we want to acknowledge that, I think Dr. Booker already did, that May is Mental Health Awareness Month. And that May 7th, which is tomorrow, is Children's Mental Health Awareness Day. And Mental Health America and the National Council for Behavioral Health have some really fantastic resources for promoting and recognizing these important issues. In addition, we wanted to support our partners at DBHDS, who will be celebrating Children's Mental Health Awareness Day a little bit differently this year. In the past, DBHDS has hosted in-person events to celebrate the day, including speakers, movie screenings, a cookie break, and tickets to baseball games, to just name a few. While we are all following the governor's stay-at-home order, DBHDS did not want to miss the opportunity of celebrating Children's Mental Health Awareness Day. Now more than ever, we need to focus on our young person's mental health. The Office of Child and Family Services at DBHDS has created 4 infographics that you can share with family, stakeholders, or post on your own social media accounts. You can find these infographics at DBHDS's website under their Office of Children and Services page. DBHCS is encouraging you to plan virtual events or reach out to families in your community during this difficult time, and please share these infographics as you see fit, along with your local resources to connect with families. If you are hosting a virtual event this year, DBHCS would love to know about it so that they can promote it on their social media sites as well. They know this year is challenging for all of us, and they appreciate your continued commitment to our most vulnerable children and families. The next resource we wanted to provide is a Mental Health America resource. Mental Health America wants you to join the Million in May campaign. There may be many reasons why you or your clients might be concerned or worried right now, and Mental Health America wants to normalize and encourage seeking help during this time. They have a screening tool on their website and have a goal of engaging 1 million individuals in participating in their mental health screening tool. This tool can be used for your own personal use or to assist members to seek assistance for their emotional well-being. The next resource is a resource from our partners, Magellan Healthcare. They announced that they are opening, or they have opened, a free national 24-hour crisis hotline for all first responders and healthcare workers who are serving on the front lines battling the coronavirus pandemic. Critical workers who call the hotline will speak directly to a certified licensed mental health clinician. The hotline is being operated by Magellan Healthcare, the behavioral and specialty healthcare segment of the company. And the toll-free number for critical workers for mental health support is 1-800-327-7451. And to learn more about how Magellan Healthcare is offering support and responding during the COVID-19 pandemic for the general public and its members, you can visit their website here. And I also just wanted to note again that while DMAS is committed to providing additional resources to our provider community, such as the ones that we just discussed, we are unable to answer any specific questions about these resources. Please contact the agency associated with the resource to receive support. And I hope you all find these helpful, and we'll continue to provide them as we receive them. And I am going to hand the presentation over to Dr. Booker to review our mental health FAQs.
Thanks, Laura. So today, we only have 4 questions, so it has slowed down a little bit, and none of these questions, I believe, is new. It's just a reiteration of a few of the most frequently asked questions. So the first one is, will we be allowed to continue under school-based TDT during this time, as most of the schools have closed in May, and the majority of the authorizations also end around that time as they get closer to the school year? If a member continues to require TDT services and meets the criteria for continued stay, the provider should be submitting an authorization request to the MCO or the BHSA, identifying all the required elements and demonstrating that the current mode of delivering the service is appropriate to meet the individual's needs. If the individual changes any service settings or the modifier is changed, then the provider will be expected to provide supportive clinical information on a continued authorization request to support the continuation of that care. Please also make sure that you are updating appropriately any assessments and documentation as that may be requested upon authorization request. Next slide. Will we need to complete the summer program assessments and authorizations for services after May 24th? Please note that within the licensing regulations, it requires the completion of an assessment for individuals who transition from school-based TDT to non-school-based programs, and providers should continue to follow those assessment requirements as listed out in regulations. The MCOs have the discretion to request providers submit for assessments for review. They do not require the assessments to be routinely attached for the continued stay requirement, but at times they may request that the assessment is submitted with the authorization request. For individuals returning from summer school-based TDT to school-based CDT, all health plans require a continued stay. So once again, if the modifier changes, then you are required to submit a continued stay. If the authorization is still good and there's time on it and units on it, then you're good to go to continue with the service. Next slide. Question 3 out of 4. Has there been any decisions or discussions regarding operating programs as usual for the summer during the state of emergency? And this is not just applicable to a particular service type, just in general. If the client continues to meet criteria for services, then the provider should request to continue those services through the summer via the service authorization request forms, utilizing, and then also make sure that you what the model of care is and under the current allowances and how you will be continuing that mode of care, that model of care during the state of emergency. Because the governor has not decided yet regarding when the state of emergency will end, all of the current memos do indicate that all provider flexibilities and allowances are through the state of emergency. So at this time, we will not be lifting or changing any of those requirements that are in the current memos. Question 4 out of 4. For community mental health services, there has been some requests from providers to provide a service-specific example of how the provider flexibilities are applied for audio-only interventions that may be combined with visual components. So here we included psychosocial rehab services as an example, where if you would do audio-only, time spent in billable activities is less than 4 hours per day, you would still get 1 unit. If you did audio only and you did up to 6 hours that day or 6.99 hours, you still would get 1 unit, and so forth. If you did 7 hours that day, you would get 1 unit because it's audio only. Whenever you add in, so the next 2 columns show that if you do in-person or telehealth using platforms with both audio and visual components, you would bill as normal. So 1 unit would be 4 hours, 2 units is up to that 6.99, and then 3 units would be 7 hours per day. And then when you have a combination of audio only and visual telehealth and or in-person, once again, you would bill as usual whenever you have that combo of both visual and audio interventions. And you would have audio only is only 1 unit, no matter how much time you did that day. So hopefully that example with psychosocial rehab will be helpful. At this time, I'm going to turn it back over to Laura to go over some of the ARTS FAQs.
Thank you, Dr. Booker. So our first frequently asked question, we have 3 this morning for ARTS, is how do we appropriately bill ASAM levels 2.1 and 2.5 individual and group sessions that are delivered via telehealth? And the answer to this question is face-to-face services shall not be required. The documentation shall justify the rationale for the service through a different model of care. Providers shall maintain appropriate documentation if the plan to provide or continue care deviates from the normal protocol or plan of care. If the providers are unable to provide the minimum amount of services required for the reimbursement of partial hospitalization or intensive outpatient programs, providers may bill psychotherapy, assessment, and evaluation codes. Providers will not be required to discharge members from the service if the provider is billing outpatient services rather than PHP or IOP codes. Question 2 out of 3. I need additional or more clarification for levels 2.1 and 2.5 and billing requirements. The answer to this is during the state of emergency, if IOPs can provide counseling for 1.5 to 2 hours and can also provide other skilled treatment services, which may include several services as defined in the ARTS manual, provider manual chapter 4, including case management, care coordination activities for an additional hour. This would equate to being able to bill the full 3-hour per diem for that day. During the state of emergency, if PHPs can provide counseling for 2 to 4 hours and can also provide other skilled treatment services, which may include several services as defined in the ARTS Provider Manual Chapter 4, including case management and care coordination, for an additional 1 to 2 hours. This would equate to being able to bill the full 5-hour per diem for that day. If the provider can provide only 1 hour of counseling and no other service, they should bill the most appropriate TPT psychotherapy code and not discharge the member from the service. Question 3 out of 3. Are face-to-face groups still allowable during the current state of emergency for ACIM levels 2.1 and 2.5? The answer is DMAS echoes SAMHSA's guidance and strong recommendation of the use of telehealth and or telephonic services to provide evaluation and treatment of patients. DMAS strongly encourages behavioral health providers to utilize telehealth or telephonic communication unless clinical judgment determines that an in-person visit is indicated or when the individual lacks connectivity. We encourage you to use the telehealth services decision tree that we have on our website, and here is the website and the actual PDF for you to download. And that is the completion of our FAQs, and I am going to hand it back over to Dr. Ward to conclude our meeting, and potentially Dr. Booker and Dr. Wood, there might be a few questions in the chat function if you want to take a look potentially about repeating some information. And if you have any service-specific questions, please send those to our mailboxes. We are not going to be answering any service-specific questions on the webinar today. And here are the mailbox addresses for you to send those questions to.
Dr. Ward, you're muted.
Thank you so much. Thank you to Laura. Thank you, Dr. Booker, for your presentations this morning. Thank you to Anna Shally for your presentation on the Support Akron resources. I do want to note that while they were speaking, I did see the chat about the question about the waivers memo, and so I did provide a link that I believe should work for people if for some reason you are one of those providers and did not receive the memo yet or are unfamiliar with how to find those memos on the DMAS website. The link, I believe, is working, and I have placed it there. I think there were a few other questions that came through that were not service specific. Having a little trouble with opening up that box in my WebEx event. I do think that one of them was from Mindy Carlin and was a question about the Support Akron stakeholder meetings. Anna, do you want to speak to who attends those meetings or their frequency?
Sure, thank you. I'll read the question. I see it here. Can you share what the weekly support grant stakeholder call is intended to do and who can participate? So this is a monthly call, actually. We have a stakeholder work group, I believe, on the second Monday of every month. So we have one coming up on Monday the 11th. And that is intended to provide updates about the Support Act grant and its current status. We also include presentations about our technical assistance and from other providers. And we intend for it to be a participatory work group. We invite any providers who are interested in learning more staying in the loop about the grant to participate. So we invite you to do that, and the information for that is on the DMAS website as well, with the technical assistance and training links as well.
Thank you, Anna. I also want to thank our colleague Nita Marino, who posted a link in the chat box to the infographics for mental health awareness. So thank you to her for that, for children and families. There was a question, a global question about telehealth flexibilities going forward. we're not withholding any information from you. We know nothing about that. We are operating in a state of emergency. And as I think everyone can appreciate, we don't know exactly how the virus will progress. We don't know how social distancing guidelines will progress. We don't know what CMS will continue to allow, because if you recall, much of the flexibility we're offering right now, particularly around telephonic delivery of services, is something that is being waived at the federal level right now. So we're really interconnected with a lot of different variables that will determine even how long the current telehealth flexibility will last. And it's hard right now for us to project out into the future policy-wise the implications. Like you, we see incredible value in telehealth and are grateful that we have these flexibilities at this time to continue to assure access for our members who are able to use telephone or telehealth technologies. Certainly, I think that this experience will give us a lot of information and hopefully some data about how that process has worked and also what barriers have come up in the process. And we did an initial telehealth survey, and we do plan to do a follow-up telehealth survey. And since the beginning, we've also encouraged providers to be looking into and trying to make system changes to allow for the formal place of service, O2, and GT modifiers to be enabled in their billing claiming system, because at some point, we will need to begin collecting that data on claims to be able to have more hard data to demonstrate what this telehealth implementation has looked like. Because right now, we're just making assumptions based on documentation, but we don't have any easily pullable data to show what is being billed as telehealth, because you all have the level of flexibility that you have. And that will be part of making the argument going forward for how telehealth should be continued or policy should evolve following the state of emergency. So that's what I can say for now. As we receive more information, I know there's a lot out there in the space. I saw a opinion piece by Delegate Kilgore on the matter. I have seen a number of articles, particularly, obviously, you're going to see those coming from telehealth vendors and telehealth lobbying about speculating on the future of telehealth and its role in the system. And I think at this point, it's all up in the air, as many things are. So we will continue to follow the progress of that federally and report in on what we see going forward. Seeing if there are other questions. And the format with which you can communicate that information will hopefully be through this second telehealth survey. But I think as we move further into the summer, hopefully we will formalize some means to collect further information about it, and also be able to report out information that we see from our 10,000 foot view and what service system is looking like right now. There is a note that the next WebEx event is in 2 weeks. So there's a question like if there were flexibilities such as group therapy being allowed to begin sooner, how would we be told? As I noted earlier in the call, we would, of course, change the cadence of these calls if we determine that, given evolving circumstances, there would be need to have another more rapid call. Or there would probably be, if major changes were made, there would be a memo release from DMAS or a blast through Magellan to our providers, as that's another not formal, but communication mechanism that we have. That's where we've been blasting the slides from these meetings and such. And the congregate care guidance was blasted through Magellan. It's just a mechanism for us to easily reach all of our behavioral health providers. So we don't know. I know that's on a lot of people's minds, and we just can't say right now because the governor has said that, it's phase 1 could ostensibly begin in 2 weeks, but as we have seen, I just want everyone to remember, as we have seen so far in this process, things change day to day. And we can't always predict what's going to happen. And that's I know that's hard and scary for all of us. And we are doing our best from where we sit at this state agency to have our eyes and ears open all the time for information that we can make policy decisions on and receive approval on those, and then get them out to you as soon as we can. So we are committed to continuing that process and doing the best we can to get the best information we have at the time out to you.
Dr. Ward, this is Laura. There is a question in the chat function specifically for the information that Dr. Booker reviewed that I think just came to me. And the question is, does the CRIS COVID reporting requirement extend beyond residential to all DBHDS licensed services? I'm not sure if Dr. Booker knows that or if that provider needs to ask their DBHDS.
I mean, I would say that because that is a DBHDS question, we would defer to DBHDS licensing and recommend that they are asked directly about that question out of respect for their process.
Yep, and it may be clearer when you go to the website. They have lots of great resources and guidance for providers, and it may be clearer when you look at the complete package.
Thank you, Dr. Booker. So I'm mindful of the time. It is 11:50, and I think that we are going to give you back 10 minutes of your very precious life today. So thank you for your participation today, and we will be in touch in 2 weeks, if not earlier, if things change. So keep on doing all you are doing. And please reach out through our email boxes if there's further support or clarification that we can provide. Thanks so much.